Welcome all. Maybe more people will be joining in a while, but since it's live streaming, people are waiting outside Zoom as well. So to introduce today's topic of discussion, we intend to talk about India's health data infrastructure, primarily on how India has been investing on the digital side of healthcare and what has happened so far. We have with us Ting Wong. Ting is a postdoc fellow and researcher at Microsoft Research. She works out of Bangalore, and she has been doing some ethnographic study on in terms of how technology design is being deployed in hospitals in India. And we have Sutit Vaidya. Sutit is a co-founder of Credible Health. Sutit is a master's in biomedical design from IIT Madras. He has been working on AI solutions in healthcare over the years. And we have Ayush Rati, who's a policy officer from Center for Internet and Society. CIS has been working on the policy side and the law side of healthcare data. So today's topic of discussion, as I was mentioning, was primarily centered around the National Health Data Blueprint, which is what was an evolution of the National Health Stack, which was proposed to the government through NITI Aayog by industry tech group Iceberg. To give a brief background of what has happened within healthcare infrastructure, the idea to push healthcare data started with the electronic health data records, EHR as it's referred to, somewhere in 2013. 2013 is the first time when electronic health records as a draft was notified and recognized, and it happened primarily because of interest in healthcare industry as well as some interest and push by the World Bank Group and the WHO, if I'm not wrong. And the EHR, electronic health records, have been modified further in 2016, and we have the proposals for National Health Stack, and currently we are at this enterprise architecture system, as the government is referring to the National Health Data Blueprint, which is a subsystem of a giant system called the India Enterprise Architecture. So health is one component of it, and part of the health data blueprint, the government wants to build health data ecosystems. So you will have health data exchanges. So this is going to talk more into that. We'll start with Ding and her ethnographic study in Indian hospitals and how technology has been used in Indian hospitals.
Hello, let me first unmute myself. So what I'm going to talk about today is going to be the field work that we had conducted in a large Indian hospital chain. So as Srinivas has introduced, I'm a postdoc researcher in Microsoft Research India. So this research is not specifically linked with the health stack or other initiative, but we thought it would be good to share some of the learnings from the ground to give you an idea what is the status quo that's happening within a hospital in terms of the digital transformation, despite all the hypes on all of the data and digitization. So within for those who don't know about this, ethnographic study is a type of sociological study that through a close look at, I guess, the environment and context, and specifically the work that goes around using observation and interview, we get a very detailed sense of, what's actually happening in the ground. So through this study, what we find is that the hospital is very invested in, electronic patient record or health record. That they are not only, so they have more than one system running at the moment. They have an existing one that they are using, and they're also investing in getting a new and updated one there. So one of the things while we were doing this study that's particularly fascinating is that we also find, on top of the use of this formal organizational digital tools, specifically the group that we observed or studied are nurses. They're also using a lot of WhatsApp to walk around the tool that this organization is using. For the reasons that the organization is using, particularly the electronic patient record, is not particularly user-friendly, to say the least. So while we were conducting this research, this is a very large hospital. They have many patients coming in daily, and they also have many hospitals across different geographic locations as well. So using electronic health record or patient record is of value to this hospital because it's a very structured communication tool, not only just between different departments within one hospital. It also helps to set a structured data and information across the hospital chain as well. And like any other electronic health record, it is designed with multiple users in mind. So it's the system that's slightly different from what we understand as a work tool or a personal tool. It's not one laptop or one desktop per worker. Many of them share a terminal or share a desktop that's within either with a nurse station or some other location within the hospital. So that is something, the electronic patient record have considered in mind, but still there's some dissonance between what has happened. And what we hope that this sharing the lesson learned today, as well as what we report back to the hospitals, for us to rethink about some of the technology design that we are implementing in the ground, and how does that affect the people who are ultimately using them. So currently the electronic health record is not the best system to use. From what we can see or what we've learned from the field, it's incredibly time consuming to use, largely due to the user interface design. So for example, the search function in this health record is particularly bad. Like it takes them takes nurses or the pharmacists a long time to just search for a patient and then be able to update information about that patient. And also because this system is rather rigid, it doesn't support in-time communication within the tool, and it often doesn't support dynamic changes. What's happening to it is that it's being used as a data repository. What do I mean by that is that, as we are imagining things happening in the hospital, things happening with the patient, the nurses goes around and input the doctor's notes into the system, and sometimes input the prescription into the system. It's often done with a delay. For one, that's because the nurses' work, have to be centered around taking care of the patient. Then later on, they can deal with the documentation of it. And secondly, it's not a dynamic system that you can do things as things happen. So that means, what is supposed to be a dynamic system is used very as a static data repository. And this happens not just, within the ward, but also during the times when patients are being admitted to the hospital. Again, when patient is admitted to the hospital, it's yet another very dynamic process that involves many players' coordination to make the things happen. Whereas this system itself doesn't really support that many users to use it at the same time. So, if we think about what really is, given all of those things said, is it a really good system to use? I do think so. So electronic health record is this one step, I guess the very first step the hospital has into digitizing the workflow they have. And it is useful for the hospital, particularly if you think about it. What it does is it makes the billing system, it makes the billing process a lot easier for the hospital, and also for whoever involved in making billing work in the hospital. And because that, another thing I have to say that I think particularly have been done well with the electronic patient record is how it is being connected with the insurance system. That again makes this billing system a lot more smooth for a lot of us who have the health insurance, that you can just go in with a cashless process that also, saves time for the patients as well. However, if you think about, because it being such a rigid system and people have to work around it, what they did was that then they used the personal tools to basically fill the gap this electronic health record doesn't fill. The tool people went to is WhatsApp. And WhatsApp, as we know, is this communication, chat app that has been adopted across the globe in many different work contexts, and as well as within the healthcare context. And in the US and UK, because of HIPAA and the NHS regulation, as well as GDPR, it's prohibited to use WhatsApp in healthcare settings altogether, in hospital by nurses or doctors. However, in India, such regulation doesn't exist yet, and similar things in China. So people turn to these personal tools and repurpose them for work. And I have to say, from what we can see, it's a very systematic use of WhatsApp to get the work they need done. However, to relate back to what we're talking about today, is there issues with using WhatsApp to walk around those formal tools? Of course there are. For one, we're using a personal tool for work. There is no longer this clear separation of what's work, what's not work, if you're using personal tool on a personal device for work. And secondly, if we're thinking about at a slightly larger scale, is that whatever been discussed on WhatsApp as information of this hospital, of the patients who goes into this hospital, cannot be saved somewhere. Never mind the security and confidentiality as well as privacy issues that's embedded in any chat tools, but also as an organization, they're losing out on some information that hasn't been captured within the formal work tool, formal communication system, that just lost within this informal tool. And even if we move this organization to adapt some organizational communication tools, for example, things that Microsoft could provide or whatnot, there is still this caveat that because the electronic patient system is one on its own standalone tool, and whatever organizational communication system the doctor or the nurses use is another system, there isn't much of a data going between the two of them. That still means even if they use an organizational sanction tool, there is going to be this data dissonance between different systems. Never mind there are multiple systems within a hospital, the legacy ones, the one they're currently using, things they haven't been migrated, things on a paper. So basically this is what we're dealing with within the hospital, despite all the hypes on the digital the data on healthcare and all of that, it is still not quite there yet. This is both because of the infrastructure, the work processes, usability, and also functionality of all the tools that we involved within a hospital. So I think with that said, what I'm trying to set is that I think potentially and ultimately we could benefit from having data about especially health data at one place, if it's secure, if it's anonymized, to understand public health at a scale, which I think is a good thing. But we're definitely not there yet. On the ground, we are using various ad hoc systems and tools to get a work done, which is very important at the moment. And this COVID-19 only stressed on that. To deliver basic work is very difficult with limited resource. Never mind this flamboyant talk about data and health stack and all of that. So this is all from me.
Thanks, Ting. We're going to move on to Sutir, who has been actually working and volunteering on some of these issues. He has a biomedical engineering background, so he can also tell what is the actual engineering procedure that's usually followed, and how should one develop these systems. Sutir.
Yeah. Thanks, Srinivas, for inviting me to this talk. Let me before I start talking about the data blueprint and different aspects of it, let me just try to give you a quick background of what I do, outside in my day job. So over the last about 4 years or so, I've been the co-founder of a company called Credible Health, where what we do is basically build artificial intelligence algorithms for radiology imaging. And so what we're basically doing is we're trying to get machines to learn to read, say, X-rays, CT scans, MRI scans, and so on. The overarching idea being that, hey, there aren't enough radiologists who are these specialized doctors to read images enough in the country. So if we can augment their abilities using artificial intelligence, then possibly we can increase the number of people who can get diagnostic care. Now, a lot of my perspective around the data blueprint and how it should work has sort of evolved from a very from a very research or AI perspective, and obviously also a deployment perspective of how to get data based systems out in hospitals today. Primarily because the way we have operated is that obviously when we started, one of our biggest challenges was, hey, how can we get all the data that we need to build these algorithms? Because we are talking about sensitive healthcare data, and these are not available in the open source, and even if you get data from the open source, they're not probably not going to look like what they would in real life. So we needed data on day one. 3 years for 2016 when we started, we needed data so that we could build these algorithms, and we went knocking on almost every hospital, that's hospital and hospital group and diagnostic center in India, going and having conversations with them. Hey, can you share data? And over the last 3 years, it's been a very interesting journey that we've managed to get. We've obviously gotten rejected by several institutions, but we also managed to sign agreements where we actually managed to get a lot of this data. And I contrast this experience with mine with what it could have been if there was a technology infrastructure layer which could have provided access to startups like me, building artificial intelligence, to have data accessibility not as such a issue that needs to be solved over the course of 1 year or so, but maybe in a few weeks or a month. And so that's sort of a quick introduction about the background, and sort of hopefully that gives you some flavor of the perspectives that I will share. And so just to give you an idea, when I read about the National Health Data Blueprint and I started talking to some folks from iSpirit and so on, the general idea that I got, which seemed exciting to me, is that is the entire concept around how data today is in silos within hospitals. Nobody has access to their own data, and if you go to another hospital today, you don't have access to there is no easy way to provide them access to your data which is stored in some other hospital records, and it's either a paper based record which is very difficult to get out, or you have to get them written in CDs, DVDs. It's a nightmare, and standards are not easy to come by either. And so if you look at this from the view from the lens of what our banking system looked like before UPI and all the interconnectivity happened that exists today, from core banking to UPI to what we have today, I think there are some parallels that I could see, which could potentially be brought to the entire healthcare data ecosystem. And that's primarily, one is it possible that patient has direct access to his medical records, irrespective of which hospital his data is saved? Can I provide access to a new hospital instantly without having to go through all the hassles? And can I do this in a way that does not involve involve the state having to aggregate, or all the private players having to come together and aggregate all the data in one centralized repository, but do it in a federated way, similar to how maybe how UPI acts today, that your data is still stored within the bank servers, and you obviously have some fiduciaries in between who sort of enable this access. But can you have a similar system? Because healthcare data can very easily get very large. So it's not just very transactional data or text data that you need. Sometimes just heavy images and signal data. It's not that easy to share or aggregate, even if you wanted to. So what is a way that you can build it such that it can be federated, and most importantly, can you move the consent of sharing this data away from the hospital to the patient. So today, for instance, in my case, even though I was using so many patients' data, we in fact today are using so many patients' data to develop our algorithms. The core the discussion we have about the ethics clearances, the commercial terms of how we use this data all happens with the hospital, and the patient is usually never involved. And because it's mostly retrospective data, consent is also most likely most often waived off. It's because there is no intervention or adverse event to affecting the patient at all. And so this is similar to, if you think about it, it's grieving the entire responsibility of the data and the opportunity of commercialization and figuring out all the terms around the data with the hospital instead of the patient. Which again I think is fundamentally not the way it should. If you think about a system where you want in data interoperability, the data rights and who gets to access, it should not be ideally be defined by the hospital. It should be defined directly by the patient. Um, and so basically, given this entire context of how of the success we have around being able to integrate the entire financial ecosystem through UPI and being able to bring interoperability, the idea was, is there a way that a similar kind of a data interconnectivity model could be established in the healthcare ecosystem? And it's a much more difficult problem if you think about it. Because one EHR, because one, the data standards are not established. So I think like as rightly Srinivas put out, EHR standards came out several years back, but the implementation of it is still challenging. If you go to any standard hospital today, you will see that most of them, I can give you a large percentage, maybe 90%, 95% of them do not have digital records. They still use handwritten records, very minimal, limited information. Only the information that is required for billing is usually just entered on the EHR. Everything else is still managed on some sort of records. Newer hospitals are increasingly entering, but you have to understand the Indian healthcare ecosystem is very different from our counterparts in developed countries, because they have time to see every patient. Here you have 30 seconds for every patient, so doctors don't have the time to do administrative work. So EHRs, even though standards exist, you have a fundamental problem. The data does not exist. The digital data does not exist. You need a way to be able to collect this information, from the hospital, get doctors to enter it in the first place. And the second part is that clinical notes is just a small tiny portion of the entire ecosystem of data. There is far more data that exists beyond clinical notes. You look at radiology imaging, for instance, you look at ECG, you look at other sort of temperature, blood pressure. There are just so many biomedical data, vital signs that can also potentially be used, and can give good information on the patient record whenever the patient needs to go to another site or another second opinion, or even come back for follow-up care. Very important information. So it's not just about clinical notes that you need to talk about. And I mean, it's not just about the EHR standards, but it's rather standards for all the different kinds of data that you can talk about. Starting even thinking about your wearables, your home health monitoring devices. How can you get all of this data ecosystem into a centralized place? And while a lot of the hospital data has some place where you can store them, maybe the hospital infrastructure. If you have home health devices, you have other kinds of devices. Where do you enter it? How does it come into the system? All that are sort of questions that need to be answered, and potentially opportunities that probably vendors can come build around the ecosystem itself. And you must understand that the EHR system fundamentally came up in developing countries primarily because of the strong incentives around insurance and payments that were linked to it. And it's no way, if you think about it, it's no way the most optimal system, because it's rather, you talk to any physician in the US and they will have nothing good to talk about EMRs. It is a very clunky interface, like Ding just talked about. But also it takes a lot of time. Doctors always almost have backlogs of patient records that they need to enter, and it's not so very fundamentally. There is a reason to go back and question, why do we need EHRs? What is critically important in these EHRs that we need to collect? If the raw data in many cases available, do we still need the analysis and the reports to be recorded? in the report itself, and how do we rethink from first principles what all we need digitized in the data in the first place. So I think that thinking is very important for the Indian ecosystem, because very simply just coming down and saying every doctor, every hospital should start using an EHR system is very impractical, and most doctors will tell you the same thing, that they're just not going to implement it. It's not interoperability, it's not the technology that and the interoperability technology that's limiting the adoption of EHRs, but rather the workflow of the software itself. um, but let's assume that problem is sort of solved, and you figure out a way to come up and assemble all the data, whether it's raw data, whether it's the bare minimum discharge summaries, prescriptions, treatments, very limited data that you collect for the purpose of insurance, and purpose of billing insurance, and let's say for whatever is needed for clinical care itself, so that the patient can get a second opinion, the patient can come back for follow-up, and lack of data is not going to come in the way of him getting best care. And in all of those places, I think the work of, or what the data blueprint tries to attempt to build in some way or form, is to have some kind of data fiduciaries, where you basically anonymize or basically delink the personally identifiable information from the information, from the data, the raw data or the clinical notes, so that those who have access to the personal identifiable information don't have access to the clinical records, and those who have access to clinical records don't have access to the identifiers, so that so that in that way you probably can there is a data provider who matches the patient identifiers, provides the clinical records in encrypted format, and the user and the application builder or the vendor on the other side, who gets only the patient records for his usage or for the purpose of transferability, but does not have access to patient records. It's there is a lot of I think previous work that's happened in the financial sector, which is sort of a good example to follow, and I'm sure there are loopholes that many of you might be aware in this space, which already exist. I am no expert in how to exactly manage the data exchange, so that it is federated and spread across all these hospitals. The biggest challenge when you compare it with what has been done in financial sector, for instance, is that the banks, there are about 10 20 banks in all of India, and maybe 5 6 large ones which command 80% of the market, and they already have a core banking system. But if you look at hospitals, there are 5,000 hospitals with more than 100 beds each, and the total number of hospitals could be nearly 10 to 20,000, and each of them have a different IT system. So how integrating who's going to go to each of these sites and build a federated sort of integrated federated data access system which enables access to all of these hospitals. So these are open-ended challenges that are going to come in the way of implementing such a large-scale system, so that you have data access. But what is important is that this plumbing needs to exist, because without this plumbing, there is a lot of potential applications and technology evolution, technology opportunities that I think we will miss out on. For instance, there are countries like Israel, for instance, which have a very strong integrated healthcare record system today, give rise to many of the leading artificial intelligence providers in healthcare, and that's purely because the government opens up the data for all these AI providers themselves, and from day one they have access to several million patients, which they can use. If India had a system where you could have data access for both development but also deployment of AI solutions, and the plumbing layer, if I may call it, of enabling hospitals to all be able to talk the same language, so that vendors can integrate, so that data interoperability is managed. It really opens up an entire playing field or ecosystem of research in sort of data driven models, evidence based care. How do you improve care? What is the most cost effective way of care? And really gives rise to a lot of innovation among startups who can potentially leverage this data and come up and maybe not just get them deployed in India, but potentially be global players, because India is literally home to one of the largest populations. If you have access to this kind and this scale of data, the potential of the kind of applications that you could build is comparable to maybe only China, and the Chinese are way ahead in terms of their mandate to open up data to AI providers who want to use that data for some kind of commercial interest. And I'll sort of try to conclude with that. But I think what is sort of open-ended and is challenging is obviously the as we talk about all this interoperability and connecting all the hospitals to get access to data. It is obviously we're talking about healthcare data. Biometric data by design is very difficult to anonymize and de-anonymize words. So you can sort of within reasonable limits try to do what is recommend what should be standard practice for anonymization. But if bad actors at any point want to exploit the data and sort of try to identify, it is a challenge, and there is no foolproof mechanism for anonymization. So it is it's something that I think requires a lot more work, lot more discussions to sort of arrive at what is acceptable. Very simply ensuring that bad actors don't get into the system in the first place, to try to maybe simplify the solution a bit. And secondly, I think even if you do build all this interoperability and data interoperability framework, what are the incentives for hospitals to actually implement the system? What do they get? How does it really affect them being able to bring more patients? Can we use this data so that hospitals can project themselves better in terms of outcomes, in terms of patients, in terms of patient experience, in terms of anything else? So the entire ecosystem around how this data blueprint can actually improve the experience and the business case for hospitals is also something that needs a lot of work, a lot of selling, a lot of thought around. And that's about it. Happy to sort of answer more and take more questions as we go. And that's
Thanks, Sudhir. I'm going to come back to you, but we'll move to Ayush to explain the complex problems of how do we even solve it and how the consultations are happening around this. Because while techies and practitioners and doctors, all of them have a different set of issues, hospitals and the entire ecosystem. Ayush can come and probably tell us more about what's happening on the consultation and what's the government doing to enable all of this, and where are the concerns, especially privacy, anonymization, and what's happening with the healthcare privacy laws. Ayush, you're up.
Thank you, Srinivas. Thank you, Ding and Sutirth, for sharing everything that you did and for raising tons of pertinent points, lots to unpack over there. I'm going to jump in and talk a little bit about sort of how we've come to this point where health systems in India are being increasingly datafied, and my work specifically sort of looks at it from the perspective of welfare systems and provisions by the state. And that is that a larger story that I want to start with. National and digital blue, which is the NDHB, and talk about a few things sort of that came up in the consultation documents and at the consultation with the ministry itself. So to sort of begin with how welfare systems have come to this point where increasing, and this is sort of from a perspective, it starts with two, and this explicit move of India move by the Indian state into sort of adoption of neoliberal governance practices. And while the term is often very loosely used, for me, it specifically entails a certain withdrawal of the state from the provision of public from the provision of public services. That includes things that we are seeing today, such as the linkage of the Aadhaar with the PDS system, tons of welfare programs across ministries, both at the center and the state, being sort of made into data-based systems and searchable data-based systems to sort of merge these silos and be able to create this perfect profile of beneficiaries. And that's really where the where so many of the health systems that I'll be talking about come in, and these are not new. So one of the oldest systems that we've been able to sort of look at is called the mother and child tracking system, which started in around 2003, 2004, under the sort of national e-governance program that was created at that point to use ICT-based tools to reach quote unquote underserved communities and to sort of rationalize India's massive sort of social security and welfare programs expenditure. So a lot of the discussions that we then see, and this is again linked directly to the concern that has been raised by several economists, sociologists, activists, and like large members of civil society at that point itself, which was that this rationalization of expense is the sort of underlying intention behind the focus that has been placed on leakages and corruption that are sort of that inhere in India's welfare systems, and that is when technological tools started being proposed as solutions. So as far back as 2007, that is when the right to food case was being argued in the Supreme Court, that is the PUCL case. In one of the interim orders that the court had laid down, building upon recommendations of a committee that had been set up, they had explicitly indicated that the welfare programs need to be quote unquote automated to make it more efficient, right? So this is again the language of so we are sort of approaching the language of privatization, neoliberalization, and have moved pretty far away from the explicitly socialist approach of the Indian state prior to 1992. And this is where the NDHB, the National Health Stack, and in its in their pervasive forms come in. But before that, there was something called the Integrated Health Information Platform. There were policy measures, the EHR standard documentation. There were policy measures such as the Disha Act, which still haven't seen the light of day. And so while initially in this sort of datafication process, there were both national and central level health programs that were being datafied, but they were still discrete and did not speak to each other. And the National Health Stack and the NDHB then seek to fix that problem, and they seek to create this overarching pervasive database. In their words, it will be the single source of truth, and it will then contain sort of deeply sensitive health information of if this imagination is given sort of its full extent, then of every citizen in the country, and will record every interaction of each citizen from cradle to grave. Again, quoting from the policy documents around a lot of these welfare programs, and also specifically the NDHB. So and this comes hand in hand with the national health policy, which again explicitly stated the leveraging of big data tools to ensure to sort of have a wellness approach to healthcare in India, and and again quoting Evgeny Morozov, using a techno-solutionist approach, uses a techno-solutionist approach to fixing underlying structural problems, right? So there is never a thought given to how let's say issues of access, issues of poverty need to be fixed, but it is assumed that the mere placing of a technological infrastructure will paper over these cracks um, and then potentially solve for these problems as well. And uh, so the national health policy then comes in, places this incredible primacy on health insurance, which also the previous discussants have mentioned. And that is the situation in which um, the the Ayushman Bharat Yojana, the ABY, comes in and seeks to, and is the latest iteration in the Indian government's attempt to provide universal healthcare. But this is still done through a focus on health insurance, and that's what is then that is being actually ensured is this indirect targeting of demand side financing. Um, so this is trying to fix problems that insurance-based models will have, not really health problems, as insurance-based models are characterized by problems of information asymmetry, moral hazard, to curtail the incentive to overuse health systems and thereby preventing cost inflations and so on. An important point to be mentioned is that the UK had attempted to digitize its healthcare service similarly, called the National Program for IT, and it was discontinued in I think 6 to 7 years. Like, it was a complete failure. There was absolute political consensus around it, and the biggest problems that and there's a bunch of literature around it. Some of the key problems that were highlighted were that it was top down in nature, did not factor in for local decision making. And this is again a problem that that inheres in the NDHB as well, and also other health data systems such as the Reproductive and Child Health Portal, or the MCTS, where um, so health workers and data entry operators are already overburdened in terms of the data entry requirements itself. But while they are the ones who still do the data entry, it is that they are never involved in the decision making around what data has to be collected and how this data can be better processed or used for making reflexive policy decisions that actually contextualize the local needs of diverse populations and underserved populations in the country, and especially given the unique contours of the Indian demographic in terms of both density of population and the geographical spread, and the inability to be accessing welfare systems in the first place. The problems around access are especially pertinent because this is an assumption that all welfare datafication measures, and explicitly in the NDHB, is the assumption is that of near universal coverage of phones. So and in something like the NDHB, which has like a complex technological framework where patients are, or I don't know, consumers of the health system are supposed to interact with this infrastructures, and that is where the consent framework lies. It's not just phones that you need to be able to access, but also regular connection to the internet, and then access to smartphones. So one problem is that of access, and then this access is is strictly mediated along gendered lines in India. So while there may be access, there may be phones present, like you may have non-smartphones present or feature phones present in most households in the country, but it is that women, for example, do not have do not have access to their personal phones, and this is a major privacy violation, especially in especially when patriarchal gendered norms um, are continue to be rampant in the country, and then also in mediating access to the online. And there is like again, there's several surveys that have been done, one including that by Digital Empowerment Foundation, that talks about how how while we may have made strides in literacy, but it's digital literacy is uh, is severely lacking. They peg it at about 90% of the population not being digitally literate. And again, this is a severe challenge, especially in terms of the infrastructure that systems like the NDHB um, propose. And this is also a function of how the decision making is happening. It's happening in our urban centers. The decision makers ascribe to a certain Silicon Valleyization ideology, and this is a sort of in a context which is strictly male dominated, and these all feed into the design of these systems, and that instead of making making welfare systems reach sort of underrepresented communities, it actually ends up further excluding them. Now, the next thing that I want to quickly mention is the standards of interoperability and content that are proposed in the NDHB. So there is a strong focus on open standards and interoperability, and that is truly commendable. But we have again tons of experience around how it's incredibly difficult to operationalize interoperability given the sort of menu of open standards that are there to choose from. And in the NDHB then specifically talks about decentralized personal data stores. So it's going to be an incredibly federated architecture with a central repository and tons of regional centers or at the sites of service providers. While on the one hand, it's already unclear what information will be stored in these repositories. So, for example, what will be in the central repository and what will be contained in the regional repositories. It may be the case that these problems further get amplified if, as Sudhir mentioned earlier, that health data can get exponential very quickly, and it sort of it may become a problem that becomes like really difficult to handle later on. The next thing I want to talk about is that of anonymization. Now, anonymization or de-identification has been a constant feature in data protection communications. The protection discourse generally over the last few years. So right from the Sri Krishna committee's data protection report, at that point itself, they had mentioned how methods of de-identification and anonymization have a possibility of failure. Earlier, Sudhir mentioned that they are not foolproof as well. And the key reason why this may be the case is because quasi-identifiers are still used to link seemingly anonymized data to respective individuals, and this is important. This is for any welfare system to work that focuses on reducing errors of targeting. The identification is going to inhere in in these systems in some form or the other, and how this is typically done even in a framework where anonymization is thought of from the very beginning is that of using quasi identifiers to link this and to sort of link it to individuals. And it's especially pertinent to mention in that why and a further tension sort of arises in so far as the NDHB seeks to also create this ecosystem where private actors and startups may be able to leverage this information through the use of open standards and open APIs. That has been a constant feature of the stack environment, so India Stack, Health Stack, and so on. And this has been a central feature. So that is where innovation, and that is regarded as the site of innovation. But the Disha Act and the Disha Bill, sorry, explicitly stated that digital health data, whether identifiable or anonymized, shall not be accessed, used, or disclosed to any person for a commercial purpose, and in no circumstance be disclosed to insurance companies, employers, etc., or any other sort of entity as the central government may specify. And in doing so, the Disha Act also squarely places the focus, places the ownership of the digitized health data upon the individuals. So, on the other hand, the NDHB sort of possibly intentionally chooses um, to sort of ignore some of the recommendations that were made at that point in time. And in doing so, sort of it talks so much about the discourse around big data frameworks as well. So the more the data, the merrier it is, and and thereby, so this linkage is crucial to driving innovation and sort of providing welfare services to potential beneficiaries. Then we also have the problems with EHRs that both Sutirth and Ding have already mentioned. One thing that I just want to point out additionally is that while their learnings were still focused to like one major healthcare chain in India, and Sutirth in some. In the case of private actors, these problems get further heightened in the case of already underserved and under-resourced settings. And the whole premise of the functioning of these systems is the requirement of more data. So those already with reduced access to digital tools cannot frequently be using EHRs or PH or personal health records as the NDHB terms it. And as a result, what then happens is that since these information systems work best with greater frequency of their use, it then so ends up happening that those who are already on the margins then further get marginalized, let alone the problems that doctors, nurses, and other practitioners in hospital systems already face in terms of being able to use these systems, and these are in settings with lesser constraints to resources. I'm gonna stop with that, and I'm happy to take any more questions on anything I can clarify further.
To sum it up, Aisha is essentially saying that technology can't really solve all of the welfare side of the challenges which healthcare is of. Like, if considering the pandemic that's going on right now, it's increasingly clear that privatization or insurance as a model for healthcare is not enough to summit it in that aspect of the welfare side of things. We're going to open up for questions. I think we have around 20 minutes. If you have any questions, please type it in the question and A. We are also running few polls, taking some feedback about how the event's been. Kindly answer some of those questions. And if you, I will let people ask the questions themselves. I have one question to Sudhir from Srikanth. Srikanth, I am turning you, I'm allowing you to talk, and you can ask the question directly to Sudhir. You need to unmute yourself.
Yeah. So my question was, Surit was mentioning that currently for research purposes, the data acquisition happens only through hospitals and not, and patients don't even are not even aware because it's past data. But how do you see with this and digital health data blueprint and how things will change? Would say patients be asked for consent for say some procedural data that happened for 5 years ago, and would they have say a chance to not be part of the research and so on?
Good question, and one that I've had multiple thoughts over. But I don't think, as far as the national health blueprint, I might be wrong, but I'm not aware of this being talked about in the blueprint as such, on how these finer elements will actually be taken care. In my opinion, I think doing something like data access dividends is very, very ambitious, and I don't think it's feasible in the near term. But I do think something like opt out of clinical research, or allowed, or maybe in the future being able to use that kind of data infrastructure to ask patients to voluntarily submit the data. Could be sort of frameworks that the government could explore. But I don't think we have answers to this question at this point. Today, the way it stands is that the hospital owns the data, and tomorrow maybe the government could, for public health use cases, mandate that hospitals open up data for say something like tuberculosis or coronavirus. Right now, the government is I know putting their weight behind hospitals to get them to share their data. But beyond public health issues, it's difficult to say how this is going to pan out. And how what role the digital blueprint can play in ensuring there is some patient consent involved in the entire process.
You have a follow-up, Srikanth?
No.
Okay. So we have some more questions on the Q&A. Sorry, it's from YouTube, where we have live streaming it. I think someone was asking if there are any good resources to learn more about the Chinese approach, and if there is any startup activity in the area of enabling EHR adherence, like from a compliance standpoint of view. Do you know anything about that, Sukhi?
Good question. Resources, see, Chinese, I think EHR adherence or implementation, I think there are multiple books on the US system and what is wrong with the US system. I personally think there are good books like Digital Doctor, and multiple books by Rick Topol, which talks about how the digital revolution in US and how bad the EMR systems are. I think the most commonly cited literature around this is the entire implementation of the High Tech Act in the US, which basically gave rise to the implementation of EHR systems across all of US. China, I've personally not myself come across literature which talks about how they're doing it. What I do know is anecdotal data that many startups in China claim to have access to data from 700 hospitals, and a scale of several millions of patient studies, which is basically unheard of for anyone in any other country. So I only have anecdotal. I have not seen any resources. If I find, I myself am looking, so I haven't found anything so far.
Could I chime in here?
Yes, please.
So yeah, so I think on like how we talk about any digital story from the outside looks pretty wonderful, but I also happen to have done field work in Chinese hospital as well. The current what we're talking about in terms of the issues with electronic patient record is being faced in China as well as in India or in any other country. And the issue that Suchira talked about in terms of the data being held by the hospital, it's also the same case in China. Yes, there are initiatives to push for more open data sharing, but that's currently not there. So just to give you an example, if a patient wants to have their digital patient record out of the hospital, impossible. The hospital itself won't allow it. Currently, the most common practice is that the hospital would give a printout version of the digital health record, and then for the patient to take it somewhere with them. Even for after the patient is discharged, the storage of the digital health record is not the storage of the old digital health record. Again, it's the printout being scanned and put back into the system. And this is not just within one hospital. There are several hospitals that are doing this. So yes, there are initiatives pushing for this, and especially, along the coastal line of China, where the digital development is further and more digital literacy. Again, a lot of hospital, because they are national owned hospital, that's the most common type of hospital in China, they are under resourced. So investing in digital infrastructure is lower on their list comparing to the procurement of an MRI machine, EPG, all of that. So this is my 2 cents.
Thanks, Ting. I'm launching the second poll. If you want for the feedback. Meantime, I'll ask one more question that's from YouTube. It's on consent. I think it's Karthik Vishwanath. He's asking, how can we build effective and meaningful consent standards from patients while we also move towards greater data sharing, especially during a pandemic when swift action is key to design interventions? It's open to anyone. Ding, can you tell us about the current consent practices in Indian hospitals?
In the consent in terms of what?
Data sharing, how are they collecting data? Are they informing the patients?
I don't think I have a good answer for that. That is something I didn't look into, because when we were doing field work in the Indian hospital, we actually specifically limited ourselves the interaction we could have with patients, because the focus would be on a hospital side, that for one. And secondly, if we were to conduct field work with patient, that process in itself is yet another consent nightmare. So we sort of, for the initial study, we decided to not get too involved in that. So I don't know. I don't have a good answer for that. However, if it's a research hospital, that might be slightly different. While consenting to the hospital of receiving treatment, there could be a subclause on consenting the hospital itself using the data for research purposes. But that's for research hospital, and that's a slightly more common practice across, not just in India, in China, as well as in the UK.
I mean, right now, whenever I go to a hospital, like if it's a fairly modern hospital, they actually create a EHR record of my data based on my phone number. So you have to go through it. And whenever the doctor actually gives you a prescription, the nurse would not let you take the prescription without scanning it. So they have scanners everywhere and they just scan it. I don't know if they're doing, well, the consent's like implied that we will take your data for now. But so there, do you have any understandings of how people can build any consent-based solutions, or is it going to remain this way?
I think it's a tough problem to solve purely because of how you get access, or how you enable the patient to be able to provide you that consent. Either you're going to end up with a system where you need identifiers all the way up to mobile number, which to provide you some kind of consent. In many cases, it's not the patient who is in a position to be able to give you consent, but often the caregiver who's going to be a family member or someone else. So I think it's a very tough problem, even in cases where you want to do a lot of trials and clinical trials, research projects. The consent is is usually done telephonically, and the percentage of people you are able to reach and get that consent itself is usually is usually you have such huge percentage drops, and it's never possible to reach all of them. So I think it's a fundamentally, I think, broken problem, and needs a lot of thinking to get it to a stage where we can talk about a system that works.
I wanted to add a little thing. Yeah, this coming from the citation in the Sri Krishna Committee around from Arthur Leff's article called "Contract as a Thing." So, where the basic proposal is that contract should be treated as a product. So then, then the regime of product liability gets invoked, and data fiduciaries are liable as if the consent form itself was a product. So then sort of data collectors would have the obligation to um, sort of take on more substantive obligations, such as showing the notice before any practices are communicated in the notice, requiring affirmative consent without any pre-checked boxes, not having boilerplate clauses, ensuring that um, that sort of that the use of their data is communicated, read, and understood before, so that informed consent can be provided. And this sort of adds in to again use a term from that is commonly used in sort of the fintech and the app building spaces, that of introducing friction. And there is an inherent challenge here, because this introduces friction, but it's important to introduce this friction, but there is a lot of resistance to this. And the other thing that I want to quickly say is that um, so while the current outbreak has thrown up solutions that are data heavy, and since I do not have the expertise to comment on there being like alternate epidemiological models that can address these, one thing to still be said is that it's not this dichotomy is a false one, that of being able to that only being data subjects would allow analyses of analyses, let's say, in an epidemiological crisis. It's that these systems should have a shelf life, which is what usually isn't the case. These then end up taking the shape of pervasive surveillance systems that extend to far beyond what their initial use was. And this is what we see with technological systems generally as well, that get implemented by the state in terms of like shifting goalposts when either their use changes or they are rendered not particularly useful for the use that they were initially thought of. And that is something which I can anticipate happening with the Arogya Setu app, for example. So the point being that this one is both a consent, is something that needs to be addressed both from the prong of consent and as well as from the prong of having sort of accountability in terms of and purpose limitations in terms of how data systems can be later misused.
Thank you, Aish. I think that was a question as well. How does Arogya Setu app kind of relate to the National Health Data Blueprint and what happens in healthcare emergencies? I guess you've answered that. I don't think there are any more new questions. Maybe we can just wrap it up. If you have any final comments that you guys want to add, please jump in. Okay, I guess that's it then. So to simply sum it up, this we can't look at the whole health infrastructure in an isolated way, because these are very similar to other infrastructure, other digital infrastructures that are coming up. For example, consent for healthcare will be similar for consent for some other online mechanisms, because the electronic consent form is the standard that is being built for any digital India solutions. So we can't look any of these systems in an isolated way, especially in terms of the society and the law and how technology can affect it. On that note, I have one final question for the poll, and please take that and we will end the session.